Hello and welcome to our webinar, Preparing for and Preventing a Payor Audit. My name is Courtney Tito, and I'm a member of McDonald Hopkins National Healthcare Team, where I represent clients in the healthcare industry, advising clients on a number of healthcare issues, including federal and private payor audits and disputes, reimbursements, corporate contracts, enrollment revocations, payment suspensions, internal investigations, and also just general advice on compliance and regulatory matters. I also assist in responding to federal subpoenas and civil investigative demands. Joining me today is Jeff Howard, president of Ray Howard and Associates, who has extensive experience in medical practice management, consulting, and representing providers in various types of audits, inclusive of internal audits, prepayment audits, and post-payment audits. Jeff will provide unique insights into these complex issues. So today we're going to cover a number of topics, including the types of audits, fraud and abuse, documentation requirements, common denial reasons in the appeals process, obligations of the 60-day rule, and COVID-19 considerations. Jeff and I will be pleased to answer questions from the audience at the conclusion of the presentation today, and you could submit your questions at any time during the webinar by emailing events@mcdonaldhopkins.com. And I think that was just up on the slide just a minute ago, but that's events@mcdonaldhopkins.com. If you submitted questions in advance of the program today, we'll also try to cover those questions during our discussion. We have a lot to cover, so let's get started. The goal of today's presentation is to give you all the knowledge of what it takes to prepare your entity so that you can hopefully avoid audits, or in the increasing likelihood that you are subject of an audit, you can efficiently defend yourself. Jeff and I have presented before together, and we'll just chime in with each other throughout the slides. So just know that we're not going to be bouncing back and forth per slide. It'll just be the two of us talking. So there's a lot of material in the slides that we have today, and we may not cover it all, but we're hoping that the slides will be a good resource for you guys moving forward. We also plan to share our real-life experiences in this area to provide color to the frameworks that are set out in these slides, and we hope to give you all practical advice and suggestions for things that can be prepared and implemented now to ensure the best success for obtaining and retaining reimbursements. We will also run through best practices for when an audit or an investigation is initiated. And as always, if you have questions after the program, you can certainly feel free to reach out to either of us, and you have our contact information in the slides. So we're going to start with this slide, which is the beginning of a basics brush up. And primarily when we're talking about audits, we're going to be generally focused on reimbursements. Were you entitled to the reimbursements that you received? That's going to be the primary focus of the framework of the presentation and our commentary as we go through. But it's important to keep in mind that these principles, for example, responding to medical records requests, which we're going to get to, are critical for other matters such as enrollment and billing revocations and appeals, terminations, etc. We'll try to point these out as we go along, but I want to make sure we keep that in mind as we move through this presentation. So this is really sort of a fundamental tenet of reimbursements that a lot of my clients personally don't always understand or grasp the nuance of, but that reimbursements from third-party payors, whether that's a federal payor or a commercial payor, are wholly dependent upon the coverage criteria set by the payor. So let that sink in for just a minute, because it's really key. It is a determination that is made in language set out by the payor. It is not something that a provider deems is medically necessary from a clinical perspective. And that distinction is one that trips up many of our clients, because what a payor deems is medically necessary and what a clinician or provider or even best practices deem are clinically medically necessary are critical for determining reimbursement. So we'll come back to this several times throughout the presentation. Next on the slide are some of what I would call the more technical requirements, such as having the correct diagnosis code, place of service code, date of service. We're seeing more denials lately from commercial payors that are based on not having the correct CLIA certification. This is more for our lab providers in the audience. And these are for codes that are being billed. So this is something else that payers are paying attention to when reviewing claims. This is something that I've seen from United Healthcare a fair amount recently. Other technical requirements that I've set forth here are signature requirements and prior authorizations.
Courtney,
Yep, jump in.
I'm sorry. One of the things I wanted to point out is when you're looking at date of service on medical policies, make sure that the date of service that you're being audited for was covered under that policy during the time of that date of service. We've seen contractors and carriers update their policies and change it. Here in Florida, approximately 10 years ago, they changed the pain management injection policies, and they were going back retroactively auditing providers, and we were able to get them to go back and realize that they were not using the policy in place at the time. When you look at the policies, look at the implementation dates. When a contractor, Medicare contractor or carrier publishes a policy and they update it, they have to list what was changed, when that was, and the date that it was changed. So make sure that when you're looking at these medical policies, they're applicable to the date of service being audited.
Yeah, and I would also follow that up with CPT codes, because we've seen that a fair amount too when there are changes in CPT codes, and we've got denials based on use of an incorrect CPT code, and there are times when that CPT code wasn't in effect yet, or the option to use a secondary CPT code wasn't available. So just because there's been a denial doesn't mean that the payer is right, and they're often wrong. So you need to be really diligent about those types of things. And again, knowing that stuff before, while you're actually going through the reimbursements, will allow you to defend against those a little bit more easily should an audit come along.
And you're correct, because if you look and have an add-on code, it has to be billed in addition to a base code. Sometimes a carrier will say, well, you shouldn't have billed these two codes together. They're similar. One may be for the initial vessel, one may be for each additional vessel, or something along that line. So make sure that if there's an add-on code that you're using it properly, and that the carriers are processing the claims accordingly.
And here's actually my first practice tip for you guys. If you guys are looking at a policy or an LCD or whatever it is that has an effective date and tells you what to do, save it. Screenshot it, save it, put it somewhere where you can have it so that you can go back and pull it and say, sorry, but on this date, this was your policy and here's the evidence of it. Because payer websites can be difficult to navigate. I'm not sure if that's by design or not, or just the sheer volume of information. And a lot of times that information can be locked behind their portals, so it can be harder to find that way too. So first practice tip is, as you're making these policy and billing decisions, make sure you keep track of where you find that information.
And don't be afraid to print out a paper copy and put it in the file. I was dealing with the clinical laboratory this morning, and we had a CMS document that was updated on November 4, 2020, and it didn't show when the original document was originated. So make sure that you keep these along the way, because this is talking about ordering criteria for COVID tests.
Mm-hmm. So we'll just get to this last point on this slide. This is another sort of key principle that I think a lot of my clients that I've seen in the past that my clients don't understand, is that most, if not all, payers will pay clean claims. Payment of a clean claim is not a determination or an indicator that the claim or service will be ultimately determined to be covered, but it's a way for providers to get paid in a more timely manner without a full prepayment review process. The payers are all going to define what it means to be a clean claim slightly differently. Sometimes it's a defined term in a contract or in a manual for the commercial payers. What this means in practice is that when you submit your claim, whether it's on a 1500 form or electronically submit, and you have the appearance of all of your I's dotted and your T's crossed, then it'll be paid. But the payer almost always reserves the right to audit or deny claims even after they've been paid to ensure that they should have been reimbursed. And this is true of Medicare, and it happens all the time. We've even had a number of clients who have told us in recent years that one thing that they'll do is just submit claims to a payer, and if they pay it, then in their mind that means it's a covered claim, even if there's a policy that would directly prohibit that type of claim. So just keep that in mind, that as a way of moving things forward, clean claims will almost always be paid.
Along the same lines, you look at prior authorization. A commercial payer will give you a prior authorization, and in that authorization, it will state, this does not guarantee payment of the claim, but go ahead and keep that prior authorization. I know states, the state of Florida and various other states, over years of trying to pass legislation that if the carrier grants a prior authorization based on the medical necessity or appropriate use criteria, which I personally am a strong proponent of appropriate use criteria, because it sets out a template of where if a patient meets certain criteria, then payment would be made. But they're trying to pass laws, so support your local specialty societies and your national specialty societies to try to get these policies implemented, that if you're granted a prior authorization for meeting criteria, that the claim will be paid and they cannot be clawed back at a later time.
Yeah, and that's actually a good segue. If we can get to the next slide, please. So one of the goals today is to provide suggestions on how to avoid those types of clawbacks from payers. So it makes sense to review what payers are looking at. And these right here are some of the things that we have listed that are the real main issues that payers are concerned with, enrollment, fraud and abuse, reimbursements and overpayments, pass-through billing, which is when you are billing for something that you have not personally performed, PCCP billing, which is a type of billing that's specific to pathology in all the instances that I've seen it. And then COVID has a whole range of issues that are going to be looked at. PPP funds, which is not the subject of this presentation, but are going to be a huge area and have already been a huge area of where payers are going to be looking, and the government. PRF funds, which are the provider relief funds that have been distributed by HHS. Again, COVID reimbursements, we're already seeing, clients come to us and ask how they're going to be reimbursed and what's the difference between reimbursements for, employee testing versus, diagnostic testing for patients. The waivers that are in place, and then, of course, fraud in all shapes and forms. It's been widely reported that the government, every single agency of the government is going to come after any sort of COVID-related funding in any of these forms. So that's just something to keep in mind.
And one of the other things, keep in mind that if you received any of these PPP, PRF, or any of that reimbursement, it will be posted on the HHS website in public knowledge. So I know a lot of providers have chosen not to accept the reimbursement as they don't want to have public disclosure of what their income will be. So keep that in mind when you're accepting these foreign funds. It may be a little late now. But the other thing, I want to drop back up to enrollment, because we've seen issues with this over the years. I'm dealing with the provider right now where the PICO system has one address listed that the contractors and ZIPIC contractors, et cetera, have access to, but it's not their pay-to address or their mailing address. And so this provider had a letter mailed to them in October that they never received, and now they're in default for not meeting the 30-day guideline. And we're having to negotiate with the contractor to say, we will meet the criteria, but you have to give us the appropriate date. So make sure your enrollment's updated, and that way you can respond timely to these requests for documentation to avoid the potential refund. And
on that point too, for as far as enrollment, we've had a sort of a rash of enrollment revocations where medical records requests have not been responded to. And primarily that was due to the fact that our providers didn't get the letters because they weren't working from their offices and they didn't have access to their mailboxes. So in some instances we've been successful in having those overturned, but it's something to keep in mind that, that these are all considerations during COVID that aren't the typical considerations. So figuring out a way to follow up on that documentation and keep it as it's coming into you.
And part of the bad thing, one of the many bad things about COVID is the fact that they've had a lot of time, they being the contractors, the ZIPICs, the RACs, they've had a lot of time to do some data mining and data comparison. And so they're looking now for abnormalities and aberrancies, and they're starting to get aggressive now that people are starting to work. And so the audits have started back up, and they're looking at every little detail, trying to find ways to do this recoupment, especially the gun-for-hire contractors.
Yep, they've always been good at data analytics, but they have really pulled out all the stops in this time period when they've been home, and they've been very effective at it. And they're adding artificial intelligence and other, methods to really hone in on that. So let's go ahead and move to the next slide. I apologize if you can hear the dogs barking. One of the joys of working from home. So this slide is really more for future reference for those of you who are not familiar with the types of CMS contractors and their acronyms. The acronyms are up there. I'll run through them really quickly. The MACs are the contractors that administer Part A and Part B claims, and they deal with enrollment and education of providers. The RACs review claims on a post-payment basis and detect and correct improper past payments so that CMS can implement actions that will prevent future improper payments. UPICs perform fraud, waste, and abuse deterrence and prevention. Quality improvement organizations are tasked with improving the quality of care for Medicare beneficiaries. And the SMRC is Noridian. They have the nationwide contract, and they're tasked with lowering improper payment rates and increasing the efficiencies of medical review programs. I think this is important because knowing who is sending you your records request or your overpayment demand or whatever it is, your audit paperwork will help you know, because if you get one from a UPIC, you know that there's a fraud and abuse consideration involved. Whereas if you get one from a MAC, it may be just a strict overpayment issue.
And from a practical standpoint, I do recommend that you keep a listing and a record of all the requests that come in, and do some data analytics on your end to see if there's something you're doing on your end that could be triggering some of this. And is the reward worth the risk, or are you better off altering your behavior and maybe not even doing those procedures at that point? But definitely make sure this is brought to the attention of management or supervision, and instead of just having someone in the medical records department respond to all these requests blindly without looking at how the data is being analyzed and compiled.
Right. And I will say the other reason to know who your contractors are is most of these websites will have, listings, like the Targeted Probe and Educate page will tell you what particular areas they're looking at. SMRC, the Noridian page, has a list of their current projects, so it tells you what the government contractors are currently focused on. And if there's something in one of your services that's there, you can take a look and see the types of activities that CMS is currently focused on, because that typically trickles out into the commercial payers as well. But that's a really good way to see what the focus is, as well as the OIG work plan. That's another area that's a great place to see what's going on. And it's important to note too, just like it says on the slide, that the audits can be conducted simultaneously by more than one of these contractors, which is always fun, but it is a possibility. So let's go to the next slide. So now we're going to turn to some of the concepts that I think tend to be overlooked. First are the definitions. These can be found in your contracts or payer manuals. These definitions are critical for determining when claims will be reimbursed. Obviously, the ones that we've talked about before, the medical necessity requirements and what are covered services. Those are really critical for when you decide what services you're going to perform and how you're going to do them. Medical policies are the best place to find out information as to what services are covered. Commercial payers typically have these behind a provider portal, but I will say with the onset of COVID, I have found more of these have come forward. Certainly all the COVID-related policies are up front and center, and they're trying to make that as easy as possible. And I have found, whether it's just in my head or not, I have found it easier to research some of the other policies, so I don't know if that's a change that was coming anyway, but I do think, that it's been a little bit easier to find those lately. The key thing about this, which we've already sort of touched on, and I think Jeff had some really good points on this, is that they're changed periodically. So you've got to make sure to go back and check them, and you need to have somebody who's responsible for checking them, whether that's biannually, annually, screenshot, print them out, put them in the file, and save them so that you have that record. They will be critical at a later date if there's a dispute. For Medicare, the coverage guidance is provided through NCDs, which are national coverage determinations, or LCDs, which set out the medical necessity criteria. And LCDs are determined by each individual MAC, so they're more geographic in location, whereas the NCDs are nationwide. These have really important information such as frequency criteria, diagnoses that are required, things like that. For example, in the tox field, you'll have very specific, this is the number of presumptive tests you can have, this is the number of definitive tests you can have, and based on what type of treatment the person is getting, they can be very specific. Contracts are another place that I think are often overlooked. In fact, a lot of our clients, when they come to us, have a hard time putting their finger on their contracts. Make sure you have copies of your contracts. I recognize that some of these can be like 20 years old, but it's important to maintain those files to the best of your ability and keep them available. This would include any amendments, but these contractual provisions will have all sorts of information as far as what's incorporated, payer, provider manuals, administrative policies, and then notice language which allows a payer to make changes to their medical policies and their coverage criteria, and how they can notify a provider and what a provider is required to do if they're not accepting those changes. Again, we've talked about provider manuals and procedure guides and notices, but those are all a variety of different areas that need to be reviewed when you're making decisions on how you provide the services and how you bill for them. So again, I just put this plug in again. What a payer defines as medically necessary is not going to be the same thing as what is clinically medically necessary. And what we're focused on in this presentation is what will get you paid. And the clinical determination is not going to get you paid. Even if it's best practices, if it goes against what's in these definitions, policies, and contracts, you're not going to get paid, or they're going to come back for it.
And you may win on an appeal, but you'll have a lot of time and effort and energy trying to win on that appeal.
Right, and it's expensive to defend, right?
Right.
That's the part that you want to be prepared for. With the advent of data analytics and how sophisticated all these payers are getting, the likelihood of getting audited is getting higher and higher, and having this information readily available at a medical records request stage versus later means you're much less likely to get drawn into a full audit if you have the documentation to back it up.
Correct.
So let's go to the next slide. Medical records requests. These are my favorite overlooked document. These are really key early communications with significant impact. I really can't emphasize enough how important a thorough and detailed response to a medical record request is to limiting or avoiding an overpayment demand. These are also critical in the recent rash of enrollment revocations that I've seen, where I think enrollment revocation could have been avoided. And some of those revocations are done without notice, which means you don't know that suddenly you're not allowed to bill Medicare anymore, and you don't have the opportunity to make a business plan for how to deal with that while you're going through the appeal process. I think Jeff mentioned earlier, and this is true for most of our clients as well, that typically this is a task, the responding to these that is relegated to some sort of billing clerk or records clerk who does not understand the importance of these records requests, and that they cannot be, oftentimes they can't simply be a response of whatever is quick and easy to find in the file. For example, labs, if a lab just responds with the requisition and the test results, that is sure to get something denied, because that's not enough information for any payer to make a determination if that service is medically necessary. So labs need to go back to the referring physicians and clinicians, which I understand can be touchy depending on your customer relations, but they need to go back and be able to get those records from their referring providers. And that, is something that should, if you have the benefit of getting a contract drafted, put those provisions in there so that that's part of their contractual obligations as well, that they will respond to these medical records requests. Payers, both federal and commercial, will use these reviews and the denials that come from it to make their determination as to the overpayment amount. So if you have 10 claims over a 6-month period, and for whatever reason the payer determines that those 10 claims are all going to be denied. And this is a very oversimplified sort of explanation because I'm not a statistical expert. We hire people to do the math. If you have those 10 claims all denied, that's what we would consider a 100% denial rate, and that can get extrapolated over that entire 6 months. So instead of looking at an overpayment of just those 10 claims, you could be looking at an overpayment that includes everything from that date of service range that has the same criteria as those 10 claims. So Jeff, I see you getting ready to talk. I don't want to cut you off.
No, I'm good on that point. I'm just getting uncomfortable sitting here.
So, getting that denial rate as low as possible, turning that 10 into a 6 or into a 1 really can have a significant impact on what that ultimate overpayment can be. And it can change, what could be a 4-figure actual overpayment that is extrapolated into a 6, 7, sometimes even 8-figure overpayment. And no, I'm not joking. I have seen that type of extrapolation in the past into something much more manageable before you even get to the position of having to go back and forth or being dragged into the audit process. So go ahead.
I was going to say, sometimes you look at it from a dollar financial standpoint, it may not make sense to do an appeal on some of these clawbacks. But you need to look at it and say, because I know Medicare looks at it from the standpoint of your error rate. And if you're above a certain error rate, they will continue to audit you. But if you go through the appeal process and get that error rate down, then they will look at that as your overall error rate being reduced. So sometimes you may go through the appeal process, and it may cost you as much to do the appeal as what you're fighting over, but you're also setting precedents and trying to make sure that your error rate doesn't lead to more audits and referral to some of these more severe outside auditors outside of the true Medicare program contractors.
And that's a really critical point, and I'm glad you brought that up. So I would wholeheartedly agree with that, and I think that's something that everybody needs to keep in mind, that you want to do as much as you can on the front end, and this is your front end. This medical records request is your front end. How you have been, sort of popped onto their radar is typically through data analytics. You may be an outlier for whatever reason. We don't know what data points the payer has put in to make you come up on their radar, and they may be perfectly valid data points. You just want to make sure you have the documentation and you're responding to these things as they come in as quickly as possible to make sure. Another point to remember is sometimes you'll get really short turnaround times on these medical records requests. I've seen some as small as 15 days. I typically have never had a problem getting an extension. Make sure you request it, because if you miss that deadline, it's as if you haven't responded. And this is going to sound like a plug for Jeff and I. It's really not. The earlier you get someone like Jeff or myself involved, the better it's going to be for you down the road, because we can really help you work on your response, get the documentation together. And even at this stage, if we're seeing, problems in how you're documenting your claims, then we can work with you on fixing that. And so it really is about making sure that you are positioned in the best place possible for moving forward should you get pulled into a full formal audit. There's also a lot of things. Yep, go ahead.
I'm sorry. I was going to say, one of the things, I know we're going to talk about the 60-day refund requirements coming up, but one thing is the quicker you respond to these areas, the quicker you can, if you're doing something incorrectly, you can stop it and make a determination, do I owe the money back, and can I refund the money before one of these outside contractors asks for everything? Because you're much better off doing a self-disclosure, or even just doing a voluntary refund, not necessarily a formal self-disclosure, than having them come through and look at the data and go full-blown on you.
Yep, that's another great point. Thanks for bringing that up. So again, I harp on these a lot with my clients. I harp on these a lot in my presentations. They're really critical. And I think every consultant I've worked with and, the attorneys I've worked with in this space would all agree they are an under sort of valued communication that really should be taken seriously. And I personally recommend that you have somebody appointed, not just a medical billing clerk, that would be the person, whether it's a title or a specific person, that is in charge of these when they come in and is in charge of making sure they are properly and timely responded to.
Yeah, the Medicaid program has, Medicaid program has a good way to do it, because you have to disclose who the financial record custodian is, and who the medical record custodian is on your registration and revalidations. So I like having that because then you have one person designated. Unfortunately, providers will change that person for whatever reason and may not remember to update in their revalidation or notify the contractor, and that could cause problems. So if you do have that, make sure that you update it anytime there's a change of employment status for your custodians, whether it be medical record or financial record.
Yep. All right, let's move to the next slide, please.
There we go.
All right, so these next slides are sort of areas that I think it's safe to say that both Jeff and I are, often involved in issue spotting in, the claim denials, and what in your records and in your policies or procedures or how you manage these claim submissions are areas that need to be looked at. The most common denial that I see is for medical necessity. Again, I'm just going to remind you guys that this is not clinical medical necessity, but the medical necessity is defined by the payer for coverage and reimbursement purposes. So the reason you get paid. On this slide, you will see the Medicare definition of medical necessity. I'm not going to read it to you other than to point out that medical necessity is determined for a particular beneficiary on a particular date of service for a particular claim. So it's very specialized. It's very individualized. It can't just be, this person, has back problems, and so anything that has to do with their back or spinal implants or whatever it is, all of that is medically necessary. No, it has to be for each date of service and each specific treatment at that time. The state definitions and commercial payer definitions are going to vary. So again, you're going to need to go back and look at the state authority, the payer contracts, user manuals and websites, the LCDs and the NCDs, to make sure that you have an understanding of what each payer has determined is medically necessary. And another key point to bring up is that for Medicare's purposes, and I find this to be true for the commercial payers as well, it's that the billing provider is responsible for obtaining the supporting documentation from a referring physician or an inpatient facility. This is, I understand, a difficult thing, but the billing provider is the provider that's getting reimbursed. They're the ones who got the money, so they're the ones that the payer is going to look to get the documentation to support that the money is there. And this is where developing a really good relationship with your referring institutions and your referring providers, putting language in contracts if possible, making sure you have an arrangement where you can get these documents from these clinicians when you need them is really key. We also work with providers to send out education letters. So, if there's a new LCD or if there's a billing practice that's really come under attention, we help providers craft letters that say, hey, by the way, this is how we're going to get paid. So we need to make sure that you understand your requirements so that we can continue to get paid. And those have been, really helpful. Labs can also do annual notices. That's something that's pulled from the OIG recommendations. So there's a lot of areas here where you can work on that relationship. So if we'll jump to the next slide. So the next sort of area are insufficient documentation errors that are listed on this slide, such as incomplete progress notes, whether they're unsigned, undated, don't have sufficient detail, unauthenticated medical records, no signature or invalid signature, and then complying with Medicare signature requirements, for example, a signature log. It's important to note so many providers are now using electronic medical records, and there are requirements for those electronic signatures. And we have seen more payers, I've seen this more on the state side, on the Medicaid side than I have in Medicare as far as specific emphasis on this, but where some of these agencies are actually looking at the metadata to see who signed it and when. So making sure that who has access to that EMR system is actually the person who should have access, so that you don't have a billing clerk as the person who can input diagnosis information and can sign off in the name of the physician. You need to actually have, best practices would be to have a separate logon for the physician so that can be traced back to whoever the authorized clinician is for those records. It could be an APRN, a nurse practitioner, whoever it is, to make sure that the right person is doing the right things in those records. That is something that EMR allows these payers to look at now, and I have seen a little bit more of that on the Medicaid side. I don't know if you've seen any of that, Jeff.
I have. I definitely have. You know, one other thing I want to add is you can amend a record, and you can have it electronically footprinted with the current date, and that is permissible by state law and federal law. So if a physician reviews a record and, you know, something, you know, they can go back 4 years on Medicare claims. You know, if you're looking at a record that's 36 months old and the doctor says, well, I meant to have this, that's not reasonable to make an amendment at that point. But if you're looking at a record that's 2 to 3 months old and the doctor may remember the patient well, maybe looking at the current visits when preparing the response to the contractor or carrier, then at that point they can do an amendment, but they need to make sure it has the current date and according to state protocol. In Florida, it's just plain and simple. You just strike whatever wasn't right, whether it's electronically or via paper, and then you just put the current date and initial it, and that's considered a legal amendment in the state of Florida. Different states have different criteria, but don't be afraid to amend it. And as an auditor, one thing that I see happens quite frequently is in the review of systems and in the physical exam, it may state that there's no abnormalities, but yet it may say that the patient presents in the chief complaint with pulmonary issues. But then again, when you do the respiratory review of systems, then it doesn't show anything that has anything to do with an abnormality. And so make sure that the content of the record is consistent with what the chief complaint is, and that this is just kind of a general medical record documentation guideline here, but list everything you can in the chief complaint, but make sure that your content, the review of systems in the plan has what is needed, and that it reflects what the patient presented for, what was reviewed, and what the provider is going to do with the patient. If they don't have that material in there, then they're not going to do well in an audit, whether it's prepayment or postpayment.
Yeah, and this is just sort of another plug for getting a consultant or an attorney involved. This is what Jeff and I do every day, all day, with clients. Hopefully y'all never get audited. Hopefully that's never an issue. And if you do, it only happens maybe once or twice in your, practice lifetime. Jeff and I see these things all the time, and we have tried various things that have worked and haven't worked as far as how to respond to these, where attestations can be appropriate, where it's appropriately and legally amending the medical records can work. So that's just something that comes with our experience, whether that's we've actually looked at the issue or we know where to go or we know how to develop arguments that will be successful. Again, it's not meant to be a shameless plug. I know it comes across that way, but it's really just the benefit of our experience. So I'm going to move us on to the next slide because we are eating up through this time. So we're going to go through these a little bit more quickly. Some other important payer communications, they're listed here on the screen. Notice of payment suspension or prepayment review, that's a Medicare form, but commercial payers also use these. They can be rebutted or terminated. So that's an option for if you get one of these. The post-payment review results and determination of overpayment, this is something else that comes from Medicare that has a corollary type of document that comes from the commercial payer where it is a wealth of information because it gives you a claim-by-claim analysis of what the denial was for, the specific documentation that is missing or is insufficient and is really critical. The other really good thing about this document is that it doesn't trigger any deadlines. So you have time to sort of parse through it and get your defense moving before the deadline is triggered. The actual overpayment demand is what triggers the appeal process in Medicare. It can be a very short time frame for turnaround, so keep that in mind. We'll get to those deadlines a little bit later. But to stop recoupment, it can be as short as 30 days, which is why you want to start moving on this as soon as you get that post-payment review results. Unless you have anything to say on that, Jeff, I think I'll breeze through that one.
Let's go on.
Okay, let's move on to the next one, please. So aside from medical records requests, this is something else that I think is really overlooked. This slide has just sort of the authority and the citations for this 60-day rule, so we can go ahead and move to the next slide. this is something that in my practice, I am often surprised when I hear that providers are not aware of the 60-day rule, haven't heard of it. It's also called the reverse false claims rule. It is surprising to me because it imposes really significant liability on a provider if ignored. It imposes potential false claims liability, which, if you're familiar with that, can be treble damages, which can be significant. Again, it's something that can't be overlooked, and it has some real specific definitions that are really determinative of how you move forward with this. So as an initial practical consideration, there is a 6-year look back. So you want to review your document retention policies to ensure compliance with that. Again, you're going to also have to comply with whatever state requirements, other requirements. Many states have longer requirements than that. So just keep that in mind, that for Medicare purposes, you're going to need at least 60 days. The 60-day rule is counted from the identification of the overpayment. And that word identify is critical because it has two parts. You need to both determine that there was an actual overpayment, and you need to quantify what the overpayment is. Only once both of those prongs are fulfilled have you identified an overpayment, and that 60 days clock starts ticking. You get up to 6 months to conduct a reasonable diligence into whether an overpayment exists. 6 months is not long. 6 months goes by like this. Most of our internal investigations come into us where you've got a Medicare overpayment demand or some other trigger, a billing complaint, something where your billing person has, done through regular compliance activities, they've found an overpayment, and you think, oh my goodness, we suddenly have an overpayment. We may have a potential overpayment. We need to do this investigation. Oftentimes, when the clients come to us, they're like, look, we understand what this is. It's a very tiny issue. We switched billing companies and we forgot to flip this switch in the code. We fixed it, so it's 3 months of claims we have to overpay. And I say, great, and we look into it, and we've got just this tiny tip of the iceberg, and the rest of the iceberg as we go through the investigation gets revealed, and that's where, you need to be really able to maneuver your investigation. As I said, it's really 8 months. You've got a 6-month investigation and 2 months to report and refund. And if we can move to the next slide, one of the really important things that the commentary to this rule talks about is that a single overpaid claim triggers this obligation. 1, it's tiny. The threshold is really tiny, but that is when a provider has this affirmative obligation to conduct this investigation. Your investigation may turn up that you don't have an overpayment, and if you can document that, that's wonderful. If you can't, then you're going to have to do the full investigation and do the report and refund. CMS can refer to the OIG, and there is authority under the civil monetary penalty law to address violations. These overpayments can be as a result of billing or clerical errors. They can be a result of Stark violations. They can be as a result of AKS violations. Essentially, any time you got paid by the government when you shouldn't have is an overpayment. And that's why it triggers this false claims liability. One of the good things about doing an internal investigation as opposed to having someone else come to you is that you have the ability, when you work with your team, whether that includes an outside counsel or outside consultant, to structure your investigation and to figure out what the true scope of your internal investigation is. Do you really need to look back 6 years? Is it something where you hired a new provider and they just used the wrong code every time, the wrong diagnosis code, you figured it out, so you really only have to look back 2 years for when that provider started. Now, you might want to look back 2 years and 6 months and look at the other providers so that you can establish that baseline, but you can structure your investigation on a variety of factors, some of which are listed here on the screen. The duration, is it limited to specific codes, specific providers? If it ends up being a really broad investigation, that's when you need to start thinking about whether you want to bring in a statistical expert so that you can do a sample of claims. So instead of looking at 2,000 claims, you look at a statistically valid sample that may be 100 claims, and that's a lot more feasible and not as resource prohibitive. And that's both monetary and staff resource prohibitive, because to do the investigation, you're pulling records and you're looking at everything. And you are looking at it from beginning to end to develop your arguments. It is a claim-specific investigation. It may be the right thing to do to hire an attorney at the beginning so that you can take advantage of attorney-client privilege to the extent that it's available. We often get engaged, and then we will engage the consultants. We typically recommend getting a billing consultant and a statistical extrapolation expert involved, depending on the breadth of the investigation, so that the consultant's work is also covered by attorney-client privilege to the extent that it exists. You will also need to keep in mind this timeline, because I'm sure Jeff will agree with me, as I said before, that 6 months is gone in a blink of an eye. And you need to have a schedule, and you need to stick to it, and you to make sure your deliverables are met. And again, you can make the determination as to whether it's going to be a claim-by-claim review or it's going to be a statistical sample and an extrapolation to determine what that overpayment might be if one exists.
And Courtney, if I may add here, the importance of the attorney-client privilege I can attest to. I had a situation back several years ago where a client did not want to put me under privilege. I ended up spending 2.5 hours with a Department of Justice fraud investigator, Department of Justice civil attorney, or the Attorney General civil and Attorney General criminal has interviewed me for 2.5 hours because I wasn't under privilege. And that wasn't a joy for anyone involved, including the client. So that's very, very pertinent to do that. And just as a side note, one of the things we see most of the refunds going on nowadays are the mid-level providers where they were billed inappropriately by the provider and they did not meet the incident 2 criteria. And there's that 15% refund that is due. And so we're able to get a lot of that nipped in the bud, so to speak, if we do our internal investigation versus having the external contractor coming through and doing it.
And I do just want to say as an aside, attorney-client privilege isn't impenetrable. It can be penetrated under certain circumstances. They're limited. It is possible. So I don't want to give the impression that if you hire an attorney that everything that happens in the discussions are forever sealed in a vault. Hopefully that's the case. It's not necessarily. It's very, very fact specific. So I just wanted to throw that out there. Let's go ahead and go to the next slide. I'm going to rush through this slide, and then I think I'm going to skip a couple of the slides in here so that we can move on to some of the more general COVID considerations before we run out of time. Briefly, I just wanted to address this page. This slide lists some of the ways to refund the money should you determine that there's an overpayment. In my experience, the vast majority of the internal investigations that we have done have resulted in a determination that a voluntary refund through the MAC is the most appropriate way to refund the money. It's also probably the safest way. Knock on wood, I typically don't get any feedback from the payers other than if we've sent a PDF of the spreadsheet of all the claims that are being refunded. Sometimes they'll ask me for an Excel spreadsheet so that they can just dump it into their system so that they can more easily apply the money. This is something when you're making the determination that you're going to want to figure out internally with your own counsel or your own compliance people as to what is the best way to refund and what are the pros and cons for each, because when you're getting into this set of self-disclosure, OIG, if you decide you need to self-disclose through that way, you won't always get accepted into that program, so you need to work through that. CMS self-referral disclosure is for STARP-only violations, so there's a variety of things that you need to look at when you're doing this refund analysis as to where you're going to refund and what you're going to refund. One last point on this, each MAC has its own procedures and its own forms and its own requirements. If you go through their voluntary refund process, it is possible for every MAC that I've done this through to do multiple claims at a time. You just attach a spreadsheet in a single form that says see attached. So that makes it a lot easier. And then you submit your check. So I would also recommend that you have a very detailed internal memo that documented the entire investigation process the decisions you made, how you decided to scope out the investigation, and why those were applicable and why those worked in this instance, so that should there be an instance where your refund of money is not enough and they come back asking questions, you have an evidence of the reasonable diligence that you have done. So let's go ahead and move to COVID. And let's go to the next slide. I'm going to skip this slide because it's pretty specific to CLIA, and I think we want to go to some of the more general. So we'll skip this one and the next one, this one as well. We're running out of time here.
I want to point out one thing on that last slide. We don't need to go back to it, but CMS has released a document stating that a provider does not have to order the patient's first COVID test, but a provider does have to order any second and subsequent COVID tests because they want to know why the patient's having additional testing performed. Aetna has a requirement that any Aetna patient can go through any drive-through facility without an order. So again, as we were saying, go to each carrier's website and find out what the rules are and make sure that you know what they are by carrier or contractor. And don't assume that everyone's following CMS, although a lot of people out there follow the CMS criteria.
And state rules are different too. I'm fairly certain that Illinois requires an authorized clinician to get a COVID test done, even if there's, you know, every reason in the world to have it done. I'm pretty sure every single lab test in Illinois is, I hope I'm getting the state right, is required to have an ordering person sign the order. So keep that in mind. The other thing to think about is if you are doing these COVID tests, how are you going to figure out if that first test has been done? And is there a way to accurately, you know, assess that? Because, you know, sure, you want to be able to believe the patient that comes in and says, no, I've never had one before. Meanwhile, they've gotten one every single day at a different provider. It's, you know, these are things that, you know, are impossible to know. So what we would recommend as best practices during COVID are most definitely going to be more rigorous than the guidance that's out there. And that is in an attempt to prevent these types of issues in the future. So keep that in mind. I kind of want to rush through this a little bit and get to some of our real world sort of COVID examples. I know, Jeff, you've got a few that you wanted to talk about, but I do want to just briefly mention these 1135 waivers. These are blanket waivers that HHS has issued that apply to a variety of topics that allow for flexibility for Medicare. These include telehealth services, EMTALA requirements, and reporting requirements for hospital flexibilities. There have been waivers of sanctions under Stark and certain waivers under Stark, but be sure to look at the specific waivers that Stark has not just been done away with. There are very specific things that have been waived. CMS has an entire web page that are dedicated to these waivers, and the states also have applied for waivers for state Medicaid programs. I want to make it very clear that these flexibilities and enforcement discretions that have been put in place for COVID are tied to the duration of the public health emergency, which I believe currently runs through January 21st or 31st. It may get renewed. So you need a transition plan. You need to document what you're doing and why you're doing it. The COVID guidance has changed drastically, and there have been new FAQs on a number of websites that change how CMS is going to be looking at these things. The commercial payer policies regarding COVID change frequently. So again, especially during COVID, we understand it's a pandemic, so that, you know, there will be some sort of, as long as you're trying to do the right thing, you're going to probably be okay, but you have to be able to document why you thought it was the right thing. And another thing to be really clear about, to my knowledge, CMS has not done away with the medical necessity requirement. Your COVID test still needs to be medically necessary. Every commercial payer that I have looked at has said you still need your COVID test to be medically necessary. A lot of people are doing employee testing. That is not medically necessary per CMS. Most commercial payers will not pay for it. So you have to be very cautious about that and how you set up those programs. I do personally believe that the medical necessity bar will be low, but it will not be extinguished, which means you need documentation. Again, have someone in charge, whether it's a title or a specific person or people, as the case may be, for following up on this guidance and regularly checking it. saving the relevant information, and documenting the decisions that are made for how you are going to proceed with any sort of COVID-related care. So I'll stop there if you have anything to add on this one, or if you...
The thing is, I think that each individual practice needs to look and see what kind of COVID policy do they need to have in place. Can they have a standing order by their medical director or clinic director of if a patient meets this criteria, we will perform a COVID test. You know, what is the billing protocol? The government has certain protocol. If a patient's not insured, a provider can sign up with HHS to get coverage for the non-insured patients, and they would be able to do that. You know, this is more pertinent to a hospital-based pathologist or laboratory than a lot of other services by the general providers on the uninsured. But there's programs out there, but you need to make sure you're following the federal guidelines, because they're even far-reaching into the private sector now when it comes to COVID. So don't just look at it and say, this is what we've always done for these types of patients. You look at it and make sure that you know what the requirements are for billing for each of these type of tests.
Yeah, and we do have
to avoid that infamous post-payment audit.
Right. We do have one question that I want to get to real quick, and then if we can get back to some of this other material, then we will. Says Jeff and Courtney, is there a software package your clients have used to deal with claim denials and software to fight and avoid clawbacks from payers? I have not seen that from my clients, and we don't have one. I don't know if you've seen that, Jeff.
I haven't seen one particularly. I think the main thing is do your internal auditing. Per the Affordable Care Act, you should have external auditing on an annual basis. I think the main thing is the auditing. Most billing software now does have the criteria of putting what they call scrubbers on there, so that you look at it and have diagnosis specific to CPT codes, or more your diagnostics and clinical tests, that's more applicable. But as far as general procedures, you don't have as much criteria. But I think the key thing is to have your internal coding people, whether they're certified coders or not. I think the key thing is just make sure that you have qualified coding people going through these claims, going through the documentation, doing it on a periodic basis, do some peer review. There's a lot to be said for coding experts. I'm recognized by numerous courts as a coding expert, but I'm not a peer. So when it comes down to dealing with is this medically necessary based on documentation? Yes, it's met the criteria of this LCD or this NCD or this medical policy by this payer, and coding experts can do that. But when it comes down to, did the patient really need to have this procedure done, you need to have some internal peer review done in your practice. So I'll encourage the peer review to be done internally and possibly externally, but then I'd also encourage the coding and documentation to be done internally and definitely externally on an annual basis.
Yeah, just a couple more things. So I think that we have seen already, and it will continue, that COVID-19 enforcement is going to be swift and aggressive. There have literally been trillions of dollars spent, and the government is not going to stand for any of that to be wasted. The AUSAs and the OIG attorneys that I've seen speak on this matter have said, as long as there's evidence of good faith attempts to do the right thing, they're not looking for those people, they're looking for everybody else. The way to prove that without an exception, every single one of them has said documentation. So the slides have, sort of detailed information about all the different appeals levels for Medicare and a commercial payer summary for audits. But if we could switch to slide 20 or 30, just really quickly wanted to leave you with sort of our final thoughts for moving forward, because we are just spot on out of time. The most important thing I would say is document, right? You need to have documentation for everything, not just what you've done, but I think what has been impressed upon me by the attorneys in government that I have, heard speak about this is documentation as to why you made the decisions you did as it relates to COVID. And as long as there's that reasonable explanation, I think there's, a chance that, they will move on. I'll turn it over to Jeff really quickly, but I'll just say that, any other questions you guys have, please don't hesitate to reach out to us, and we'll do our best to answer them.
One thing I want to flash back on real quick is Medicare has these target payment and education audits. if you get audited and getting a TPE, they'll go through round one, and depending on how successful you are, you'll either pass it or consider it fail. They'll do an educational session with you, and then you'll go to round two if it needs to be looked at again. Make sure that you participate in that educational session. Have people on there that will listen and interact with the education. We have seen great success in dealing with the Medicare contractors when providers participate in the TPE in that educational session. So if nothing else, it tells you what they're looking for, so you know what to make sure that you document and what criteria that they'll be auditing you on the next time. So you can at least have that cleaned up till the next problem arises.
Right. So I just want to say, Jeff and I do this every day, so we're following on these developments. We're doing the best we can to keep ourselves up to date on these payer audits and related topics. I know that for myself, I write about these things and I speak frequently. I know Jeff and I have spoken together before. But again, if you have any questions that didn't get addressed today, you can go ahead and email that events@mcdonaldhopkins.com. It's in that green bar on the slide that's showing right there, and we will do our best to get back to you with an answer. And we hope that you enjoyed it and that you got some useful information out of it. And thank you and happy holidays.
Thank you, Courtney.